pre-hospital team based on their senior critical care doctor and a senior ambulance paramedic. And they will leave the aircraft basically as soon as it's safe to do so and proceed to the accident site. Now, in some situations, we're actually the first responders to the scene. In other situations, there will be ambulance resources at the scene. So this is a simulation of a unconscious driver in the front seat, and one of the things about the treatment of the patient at the scene, which is interesting to medical people, is of course you don't have all the resources you used to, and in particular access to the patient can be limited. So often what will have to happen is what we call a sequential or two-stage resuscitation, where standby or intermediate measures are performed until we can get the patient into a position where we can perform more definitive measures. So some things such as intubation can be very difficult to perform when the patient is trapped in the vehicle, particularly if there's major deformation. So sometimes it means something like a surgical airway, or other times we may be able to make do with a laryngeal mask airway. Familiar to those who do anaesthesia. As far as the vehicle goes, this is a vehicle that's actually been put together on a trailer and is designed basically to be able to simulate a crash and to be taken apart in the same way that a fire brigade or police rescue team will take it apart with the jaws of life and then put back together and used again. So it's sort of like the Lego equivalent of a crashed vehicle, you take it apart and rebuild it. And Chris, who's in the back seat, is filling the role of someone like a fire brigade officer or something who would be involved in the technical aspects of the rescue. In this sort of scenario, you've got to have a balance between the rescue aspects, which is just sort of get the vehicle apart and get the patient out. Now, if you ignore patient care during that time, you may get the patient out quickly, but they may not survive the experience. On the other hand, if the medical team monopolises access to the patient and prevents extrication, similarly, you may not get the patient out in time to prevent their demise from their injuries. So you have to have a balance of measures and constantly work with the team on scene to find the best compromise between rapid extrication and necessary medical stabilisation. Now, in a real scenario, the team would also be wearing hard hats and and eyewear and things like that. But for the purposes of this, we'll do without it. Sometimes this vehicle can also be placed inverted if necessary. And in situations where we are actually first on seat in this situation, we may actually use our pilot and our air crewmen as additional medical assistants when they receive training to enable them not necessarily to perform medically independently, but to be able to assist with necessary procedures. But in about 80% of the time, there is at least one ambulance or one other emergency vehicle on scene before we are. But in remote locations, it can be the worst case scenario of us being the only resource on scene. And treatment more or less follows the AD to trauma ABC, but Ken Harrison, who has put together our pre-hospital trauma course, which is now available to a wide variety of people, including the armed services, talks about, rather than a primary survey, a zero survey. And because of the zero, because it consists of 4 O's, the patient should be oxygenated, their vital organs, which can be anything as simple as putting an oxygen mask on, to as complex as having to establish an airway, decompress speech and pneumothoraces, and give a massive transfusion to actually give somebody a blood pressure. So that can be very simple or very complicated. The second O is on a stretcher, which means get the person out of the vehicle and onto a stretcher, able to be transported as soon as possible. The third O is options, and that is, what else do I have to do to get this patient safely to hospital? What can't wait until they get to hospital? Or in the case of somebody still not able to be transported because they are within a vehicle, what other things do I have to do that I prefer to wait till the patient got to hospital, but I can't because they need it now? And then the final O, the fourth O, is the O for out of there. In other words, get the patient to hospital as quickly as possible and to the right hospital. So under most situations, about 80% of our adult patients are transported to the nearest trauma centre by road. If the patient's paediatric, because there's only 2 paediatric trauma centres, we have a much higher likelihood of having to fly them because the distances are greater to get to either Sydney Children's or New Children's at West. So a patient at this stage has had a temporary airway placed with a laryngeal mask and is having their ventilation assisted while they're being got out onto an ambulance by board. This can be simple, relatively simple, or difficult depending on the particular vehicle, the location of the vehicle, how much intrusion of other things there is into the vehicle, and how easy it is to remove structures. Sometimes the roof has to be peeled back or the patient has to be taken out through the back window of the vehicle. But if it's your vehicle, you wouldn't normally want it after the fire brigade has finished with it. They're very good at cutting vehicles up. And some of the things we do wherever possible, we obviously try and provide people with cervical spine immobilisation. Also because people in vehicles have a fairly high rate of pelvic injury, some of which may not be diagnosed until later, we tend to put a pelvic binder on most people on suspicion of a potential pelvic injury, and that has actually proved probably to prevent life-threatening pelvic hemorrhage in a number of cases we've done. So the patient is now being assisted again with ventilation through a laryngeal mask, and additional hands are being used to get them out. Now at this stage they would then be placed on an ambulance stretcher or possibly the helicopter stretcher, and any further immediate measures would take place before the patient was then transported to hospital for definitive care. So the timeline for this has been about, including extrication, about 8 minutes, which it can be longer than that if the vehicle is more difficult to cut apart. But just setting up now to place the definitive airway. And these packs are basically designed to be placed and to come apart into a whole series of kits which are colour-coded so that non-medical people like policemen and fire brigade officers at scene can pass appropriate kits based on colour. We have oxygen, suction, a range of drugs, a range of airway control equipment for surgical control of hemorrhage and placement of chest drains, and a range of splints, bandages, and full monitoring, and a ventilator. So basically everything that would be available in the resuscitation room of a major trauma hospital is pretty much available to us on scene, with the exception of X-rays and other diagnostic facilities. We can, even if necessary, do invasive blood pressure monitoring if we have somebody who, for example, is trapped in a vehicle for a long period of time, but normally that would be too much to establish, so we wouldn't tend to do it. What we do is the doctor standing the surgeon at the moment on a couch which has pre-drawn drugs. We have half a dozen different sedative and muscle relaxant regimes available to us depending on the individual status of the patient. Some are more suited to people who have an isolated head injury, others are more suited to people with multi-trauma. Not every drug regime is suitable in every situation, so there's no one size fits everybody, unfortunately.
While you're doing that, tell me when you're ready, I'll just have a quick look.
So while we're setting up for therefore this patient is still being oxygenated through their temporary airway and setting up to place a more definitive airway. As the patient was 2 minutes outside the hospital, you might elect to go to the hospital and do the procedure here. On the other hand, the further away from the hospital they are, the more you are likely to have to do before or during transport. And some conditions, obviously like bleeding or pulmonary confusion, the patient tends to not look too bad initially and get much worse later on. So you have to be prepared not to only to do the immediate stabilisation, but continue to assess and do ongoing stabilisation. That's the approved technique to do the substance in the hole. So a standard regime, for those of you who have anaesthetic or emergency medicine experience, is some sort of variation on a rapid sequence type induction where we try and provide a definitive endotracheal airway with a minimum potential interval to allow where the patient is without airway protection. And intubating people on the ground can occasionally be difficult, and there are a variety of positions that have been suggested, some lying on your side, some people squatting. It depends on the person's sort of individual preference and flexibility.
That's better, Aaron.
As actors, they make good doctors and paramedics. As this course or similar course that is involving scenarios like this is now being made available to people as part of a travelling pre-hospital trauma course. And one of the groups who are doing this are the military medical personnel and medics who are involved in places like Iran and Afghanistan, so we're involved in the teaching team, and we have some fairly high fidelity simulators that can produce a whole variety of fairly nasty scenarios. Those of you who've seen the film This is Spinal Tap will remember that there was the band Spinal Tap had the amplifier that went up to 11 because that was so much better than the amplifier that went to 10. We have a fidelity simulator that goes to 11, which is so much better than 10 because 11 is full darkness mode, and that's anything that can go wrong. Whatever procedure you do will go wrong, and they gradually ramp up the training until everything goes wrong when you do something and see how you cope with getting around it. So this one is being relatively straightforward. We can simulate failed intubations, tension ambulatory series, people with disrupted airways after you intubate them, and a whole variety of other things. And the idea of the training is a bit like the Special Air Service principle of war is hell but training should be worse. We try and make the scenarios that we get equal to the ugliest thing you could see, plus 10%, would mean anything you come across at scene needs to be a pleasantly straightforward by comparison. So at this stage, patient will be taken to the most appropriate transport vehicle.